the next topic is going to be on the role of atezolizumab in the first line setting in metastatic NSCLC. And I am going to take up this talk, and in the next 20 minutes or so, we are going to discuss what is the best treatment for first line NSCLC now, especially in patients who are not having a driver mutation in the very beginning. Next slide, please. So these slides have been given to me by Raj, who's the sponsor of this session. This is what we are going to discuss: the little background about NSCLC, what is the evolving landscape. The three studies that I'm going to speak about is Impr110, 150, and 130, and later will be the summarization. Next slide, please. So we do know that NSCLC is a very important malignancy. If we talk about in our daily practice, about 80 to 85% of all lung cancers are NSCLC. Lung cancer is really there at the top if you talk about the Indian data or the world data in Globocon 2020. The median age is always on the higher side, 65, 70. Most of these patients present at a late stage when the patient is already metastasized to the malignancy has metastasized to other parts of the body. And these patients can have histology of squamous or non-squamous, and most common non-squamous histology is adenocarcinoma. Most of these patients are smokers and will mostly have a histology of squamous histology, but there are about 15 to 20% patients who will have a never smoking history, and these are the patients where mostly the histology will be found as adenocarcinoma. We do understand and know that adenocarcinoma histology has a better prognosis compared to a squamous histology. Next slide, please. Yes, there have been instances when the treatment of lung cancer has changed, and there has been a paradigm shift in the last decade or so, or maybe 15 to 20 years now. Previously, there used to be only the option of chemotherapy, and after that, chemotherapy plus minus anti-angiogenic drugs. Then came the era of targeted therapy post 2007, when Dr. Tony Mock told us about the EGFR mutations. And then there has been a host of targeted therapies which have come up for oncogenic driver mutation positive patients. But very importantly, we are talking about immunotherapy here, and we are talking about those subset of patients who do not have oncogenic driver mutation in the very beginning. Next slide. So it is very clear that if a patient has an oncogenic driver mutation, then the survival is definitely better as compared to patients who do not have an oncogenic driver mutation. And the Kaplan-Meier curve on the left-hand side of the screen tells us this very clearly. Also, very importantly, one has to understand that if we have a pie chart, which is on the right-hand side of the screen regarding the oncogenic driver mutations, most common mutation is the KRAS mutation, followed by the EGFR mutation. But look at the pointer, about 35% of the patients will not have any oncogenic driver mutations. So what about them? Why are these patients really being left out as far as the clinical trials are concerned? Probably in the last 3-4 years, they've been addressed. But then before that, there was not much talk about these patients. These 35% patients is like 1/3 of the whole gamut of patients. And can we do something to improve the survival of these patients as well, is what we are going to talk about. Next slide. So certainly, like I said, that there is an important need to address these 1/3 of the patients, and these patients have been addressed in 3 studies as far as the first line use of atezolizumab, either alone in a particular subset of patients or in combination with chemotherapy is concerned. And these are the 3 studies that we are going to speak about. First study that I am going to talk about is the Impr110 study. Next slide, please. Next slide, please. So this study enrolled both squamous and non-squamous histology patients, very importantly, and this was a study design. It was a stage 4 non-squamous or squamous NSCLC patients. Remember, all of them had to be EGFR and ALK negative, very particularly. And PDL1 selected population, they had different grades of PDL1 expression. We'll just talk about that. And then they were randomized 1:1 to receive either atezo monotherapy, 1200 milligram Q3 weekly as a standard dose until progression or toxicity, or if it was the control arm, it was chemotherapy, and chemotherapy could be gem platinum in squamous or pemetrexed platinum in non-squamous, followed by pemetrexed maintenance. This is what the thing was. And primary endpoint was overall survival in the in the whole population. Next slide, please. So very importantly, like I said, that they had a graded PDL1 expression. So you have to understand that there were about 35% approximately patients in both the arms who had a PDL1 expression which was on the higher side, that is more than equal to 50% if we look at the tumor cells, or more than equal to 10% if we look at the immune cells. And then there were patients who had a lower expression, intermediate and low expression as well. We are going to speak about the subset of patients who had a very high PDL1 expression, that is tumor cell population more than equal to 50%. Next slide. If you look at the baseline characteristics, they were well matched. Most of these patients had a non-squamous histology, like I mentioned in the beginning. Most of these patients, some of these patients were Asian ethnicity, and most of these patients had a good performance status of PS0, and they were both well balanced and matched between arm A and arm B. Next slide. So I said that the primary endpoint was overall survival in the whole population, and this was the secondary endpoint, which was the overall survival in the high PD-L1 expression group. And look at the overall survival. There is wide gaping of the control arm and the experimental arm, and this is the overall survival Kaplan-Meier curve. If you look at the 6-month OS and the 12-month OS, then there is certainly a very important difference, with the hazard ratio being 0.59 and the p-value being highly significant at 0.0106. And the median OS was 20 months in the atezo monotherapy arm compared to 13 months in the chemotherapy arm. So a delta of 7 months with a high PD-L1 expression makes this a positive study. Next slide. And if you look at the OS in the key subgroups, these were pertaining to the high PD-L1 expression, then whether the patient had a squamous or a non-squamous histology, both of them benefited. If you look at whether the patients used to smoke or not, all of them benefited. And even the OS, even the PS01, they benefited. So which means that it was a positive study, and a squamous or a non-squamous histology population with a high PD-L1 expression, we may not give chemotherapy and resort to a atezo monotherapy and aim to achieve a higher OS compared to only chemotherapy. Next slide, please. If you look at the subsequent treatment, if the nearly 1/3 of the patients in the, even then crossover was there, and good number of patients achieved subsequent immunotherapy, and still the benefit was maintained. Next slide. If you look at the PFS also generally, it may not be seen in an immunotherapy trial, but here the PFS also was significantly better, 8.1 versus 5 months in the favor of experimental arm. Next slide. And even the response rates to approximately 40% versus 28%. So this also was significantly better, more the number of responses if we have a high PD-L1 expression and using atezo monotherapy. Next slide. The updated safety analysis tells us that yes, in the atezo arm, there are going to be more immune related side effects, but that is understandable, and there nothing alarming was really found out, and this is something that over the years we have already learned to how to use immunotherapy, and this was manageable. Next slide. So if you look at chemotherapy, more of anemia, more of nausea, neutropenia is certainly bound to happen. More of transaminitis is there in the immunotherapy arm, and more of IRAEs, like I said, but they were manageable. Next slide. So the conclusion of Impr110 is that if you are going to speak about atezolizumab as monotherapy, it certainly was a positive study if you are looking at the PD-L1 high subset of NSCLC patients. This was both the histologies, very important to remember, squamous or non-squamous. We don't have to bother. If we have a high PD-L1 expression, we can easily use atezo monotherapy. Higher response rates, higher PFS, and certainly the gold standard endpoint overall survival also was high, with the HR of 0.59 and p-value being significant. The safety profile was also manageable, and the patients had a longer treatment exposure than patients who were treated with chemotherapy. Next slide, please. After IMPAR-110, we have IMPAR-150 now, and this is pertaining only to non-squamous histology, a phase 3 study where atezo plus chemotherapy plus bevacizumab also, that is ABCP regimen, was used in the first line in non-squamous NSCLC patients. Can we have the trial schema, please, in the next slide? This is the trial schema. And if you look at the trial schema, again, stage 4 NSCLC patients, non-squamous histology is a very important point. And these patients were chemo naive, and they were randomized to 3 arms. One was the control arm, which was paclitaxel, carboplatin, and bevacizumab. There was a second arm, which was paclitaxel, carboplatin, bevacizumab, and atezolizumab. And the third arm was atezo plus paclicarb. And all these arms, they had a maintenance according to the protocol. And if you see the atezo plus bev plus paclitaxel arm and the paclitaxel plus carboplatin plus bevacizumab arm, they are category 1 recommendations. So it was a very well designed study where they were trying to compare the 2 category 1 recommendations by NCCN and pitch them against each other and try to see the co-primary endpoints being the PFS in the intention to treat population and OS in the intention to treat population. Next slide, please. Very important to remember that all these patients had EGFR and ALK negative. Like I said in the beginning, these are trials in the oncogenic driver mutation negative patients. We do understand that there is a rationale for using atezo plus bevacizumab combination. Bevacizumab is a VEGF inhibitor. It inhibits the dendritic cell maturation, and it also normalizes the tumor vasculature. What it does is that it decreases the activity of the stem cells and the T regulatory cells. Chemotherapy-induced immunogenic cell death can trigger the release of tumor neoantigens, and once the tumor neoantigens are released, then the mechanism of action of atezolizumab is exactly on those, and that is why it improves the action of atezolizumab. Next slide. So the baseline characteristics, they were well matched between all the 3 arms. Very importantly, one has to remember that they were mostly patients who were having a good performance status. All these patients are non-squamous histology, as we have already discussed. About 50% patients had a high PD-L1 expression. Very few of the patients had EGFR and ALK as well. About 10% EGFR, 2 to 3% ALK, and then very importantly, about 15% of the patients had liver metastasis in the beginning, and they were all well balanced between the 3 arms. Next slide. So this is the endpoint, which was the overall survival. And overall survival, as you can see, the control and the experimental arms, they have a good separation of Kaplan-Meier curves, be it the landmark OS of 12 months, 18 months, or 24 months. And there is a steady improvement in overall survival with a hazard ratio of 0.80 and a median OS of about 20 months versus 15 months, a delta of 5 months at that. This is comparison between arm B, which is atezo plus bev plus pacli-carb, with arm C, which is bev plus pacli plus carb. So this is a very robust data because bev plus pacli plus carb also has been used in many trials, and one or two trials have shown that there is OS benefit of using bevacizumab. So over and above use of bevacizumab, if we add atezo, and this is remember in patients who are all comers, these are patients who are having any amount of PD-L1 expression, but they have to be a non-squamous histology. Atezo plus bev plus paclicar combination is been seen to have an improvement of OS compared to bev plus chemotherapy arm. Next slide. The response rates also, they are higher in ABCP regimen, and of course the response rates are the highest if you are going to talk about a very special subgroup of selected PD-L1 high patients. But then even if we talk about the intention to treat population, 56% response rates was never seen with only immunotherapy. We just saw Impr110 where the response rates were about 38%. So certainly addition of a BEV plus atezo plus chemotherapy has increase the response rates to in excess of 55%. These are the response rates which you expect from a TKI, but then this is what we see here, which is certainly a very very heartwarming for an oncologist. Next slide. Even the OS, if we see, it was observed across all the subgroups. Of course, the quantum of benefit was the highest in the PD-L1 high, but then if the PD-L1 was low, even then the benefit was maintained. Next slide. So what about patients who are EGFR mutant? So these patients, of course, had received EGFR TKIs in the beginning. Next slide. So this was in the second line that it was being used, that is ABCP regimen. We do understand and know that these patients are underrepresented in most of the clinical trials. This was a trial where they did have a representation. About 10% of these patients were there in this study. Next slide. And if you look at, although a small number, but if you look at the Kaplan-Meier curves, we see that if you look at the progression-free survival, it was about 9.7 versus 6 months. So and it was statistically significant. If you look at the hazard ratio, it was 0.59. So an important take home that if we have a EGFR mutant subgroup of patients who have had a progression on EGFR TKIs, then probably these patients can be given this combination, and an improvement of PFS against the standard BEV plus Pacli plus CAR can be expected. Next slide. There is another subset of patients. Yeah, so even the OS was improved in these EGFR mutant patients. Next slide. There is another subset of patients which is the response rates also were improved. Next slide. About 5% of these patients, including this, also generally do poorly, and also are these patients will have a shorter OS and PFS. Next slide. And we see that even in liver metastasis patients, this combination was working well compared to the control arm. And if you look at the PFS was higher, and the delta of PFS between, next slide please, delta of PFS between ABCP versus BEV plus Paclicar was higher. And we look at the Kaplan-Meier curves, they are separating widely. Next slide. Even the OS benefit was there if you look at the liver metastasis. Yeah, next slide please. Next slide please. Response rates also were higher, and early separation of Kaplan-Meier curves again is a very reassuring point for us that even liver metastasis patients, next slide, which are considered conventionally bad patients, this combination has been seen to improve the overall survival. So in key subgroups, next slide, be it a bulky disease patient, be it a patient where there is, next slide, where there is EGFR mutation, be it a patient where there is liver metastasis, this combination has worked very well. Next slide, please. So if you look at the efficacy of high and low volume disease, even in patients who are having a low volume disease, this combination worked. But then in patients who had a high volume disease, again a proverbial bad subset of patients, these patients again did well with this combination. So this combination is basically an axe which you can use to solve a lot of your difficult subset of patients. Next slide. Next slide, please. The tolerance also was good. We can skip this in the interest of time. Next slide. So the conclusion is that this is a positive study with which it met its primary endpoint. First line use of ABCP regimen is the standard of care now, and clinical benefit was observed across key subgroups, and especially patients who are actually known to not do very well. Next slide. Next slide, please. Now we are going to speak about the Impr110 study. Next slide, please. And Impr110 study actually is a study again in the non-squamous histology setting. And next slide, please. Next slide. It is a phase 3 study of nab-paclitaxel and carboplatin with or without atezolizumab in the first line NSCLC patients, again non-squamous histology. Next slide, please. So this is a combination of atezo plus chemotherapy. There's going to be no bevacizumab here. And this is the trial design. Again, NSCLC patients who are non-squamous histology, PD-L1 H expression stratified with a good PS and EGFR ALK being negative. Patients of liver metastasis were allowed. About 700 odd patients. They were had a 2:1 randomization to receive either the control arm of chemotherapy, which was nab-paclitaxel carboplatin, or it could be nab-paclitaxel carboplatin, or if the pemetrexed was given, then pemetrexed maintenance, and the other could be atezo plus nab-paclitaxel plus carboplatin, followed by atezo as maintenance therapy till progression or unacceptable toxicity. The doses were very standard which were used. The use of nab-paclitaxel actually was to provide a potential steroid sparing chemotherapy regimen. Next slide, please. The co-primary endpoint was PFS in the intention to treat population and OS in the intention to treat population. A well-balanced based on characteristics in both the arms, where we see that liver metastases were present in about 15% of the patients, about 15 to 20% of the patients in both the arms had a high PD-L1 expression. About 50% of the patients were PD-L1 negative as well in both the arms. Next slide. This is what we actually saw when we look at these results. The PFS was improved in favor of atezo plus nab-paclitaxel carboplatin as compared to only nab-pacli-carb in the intention to treat population, with the 12-month OS being the 12-month PFS being 42.5% versus 14%. So nearly that 3 times of PFS was seen with the atezo plus paclitaxel carboplatin. If we talk about the median PFS, it was 7 months versus 5.5 months. Next slide. If you look at the OS, even OS was significantly better. OS of 40% versus 30% in 2 years, and the median OS was about 19 months versus 14 months. The delta of 5-month OS was seen. Next slide. There were about 40% patients who crossed over to the atezo arm in the chemotherapy alone arm, but still the OS was seen. If you look at the subgroup analysis in the forest plot, again you see that this was all restricted to the non-squamous histology. The highest PD-L1 expression, they also benefited. The PD-L1 low expression patients also benefited, and patients who were having liver metastasis, they benefited more than patients who did not have a liver metastasis. Next slide. So very importantly, in this population, there were very few EGFR and ALK positive patients, but they did not have the benefit of the addition of atezo to chemotherapy. Next slide. Even the response rates were improved with atezo combination as compared to only chemotherapy, be it the intention to treat population or the high PD-L1 expression population. Next slide. And the safety profiles also were consistent with all the previous trials that we have discussed. Next slide. So important conclusion is that this is again a positive study in non-squamous histology patients where atezo plus chemotherapy can be added to chemotherapy alone, and this would result in an improvement in overall survival. These patients had a manageable safety profile, and but this combination was not proven to be effective in patients who were second line EGFR or ALK positive patients post the use of TKI. So we have to carefully select our patients who would really benefit out of this particular combination of IO plus chemotherapy. Next slide. Yeah, so with this, I thank you all for your patient listening. The important summary is that edizolizumab has got an important role to play in the first line metastatic NSCLC patients. We should use this combination while carefully selecting our patients so that the benefit of IO, either in a monotherapy or in combination, can be passed on to our patients. Thank you.